This is kind of an airline conference too, because I'm going to reach out to the airline industry like Mark did yesterday. And I'm going to go with an analogy here that might be a little bit of a stretch, so if it is, then tell me that's okay. But we're going with it anyways. So, this is my talk, not yours. So I'm going to go with the analogy of a black box. And I've dubbed the title of this conversation, Tapping into the Black Box. It's a journey towards optimizing hospital patient flow with Medworxx. We're certainly not there yet, and we're still on the journey. But the reason that I call this the black box, which is really not black if you look into it, which surprised me, it's orange or blue in most cases, which would be interesting when you're searching for it. You would be looking for the orange box, not the black box. But so the concept of a black box has evolved over time, but essentially what it is a history of flight's activity, all the vital information, incredibly valuable information in there, but it says right on it, do not open, like don't tap into it. There's all this great information in there, but don't touch it. And you can only tap into it after something bad has happened and you really need to dig into things. And the way that the airline industry is going is taking advantage of this concept of the Internet of Things and the connectivity of everything to really take advantage of technology that's out there now and take all that vital information that you get in a black box and actually do great things to monitor in real time as well as afterwards issues that you may have on a flight. So you can correct, hopefully, in real time if you need to, before it becomes a disaster. And if there is a disaster situation, still get that benefit afterwards. And the reason that I'm talking about this is that we, up until recently, we were treating our Medworxx system essentially as a black box. We were dumping valuable information into it. Our patient care coordinators, most of them are back at the table back there, going to heckle me in a bit. They were dumping all this great information into Medworxx, using it on the front lines, but we weren't doing anything with it. And to be honest, we're still not great at doing anything with it yet, but that's on our journey, and we've definitely defined that. So what we want to do is take Medworxx from being this black box, the upgrade being part of that, to being kind of something that we can utilize in real time to help patient flow as well as afterwards to diagnose problem situations, fix them, and prevent them from happening again. So hopefully that concept works. It's not too far off. So a couple objectives from the talk today for us. One is to highlight the importance of considering your upgrade, if you're going on the upgrade journey, as a first step in a continued journey, not at all the end state. And to share some strategies for effective management of that project and to try and help you get the most out of your Medworxx upgrade platform. So a little bit about us. You see on the map here, we're in Toronto right now. North of the city, that's where we are. The red box on here that's highlighted, that's our region, our local health integration network, somewhat similar to a trust from what my understanding is. So we're just north of the city of Toronto. We're a rapidly growing community, greater than 20% growth rate versus a provincial average, which I think is about 12%. We have greater than average population aging, and we have the most diverse region in Ontario. So you can imagine all the experts in the room here on patient flow, how much complexity that introduces to manage beds in a hospital, to manage length of stay, all those sorts of things. In Maryland, I'm sure, and the team can relate to a lot of this. They're just right up here in Newmarket. So interestingly, yesterday, I was kind of inspired by the Liverpool group. They have the Beatles that came from there. So I looked yesterday on who the famous people were from Richmond Hill, which is where we are, and there's not really much. We have Mike Camilleri, hockey player. Anybody know that guy? and Elvis Stoico. Yeah, woo! My fiance would be really happy about that, but no Beatles. So quick facts about us as an organization, if you're not familiar with us. Almost 20,000 admissions last year. We've, I should know this, but sorry, about 520 beds, a mix of acute care, complex care, and long-term care beds that we have in the organization. Most of this is about acute care beds, of which we have about 260 or so. Our emergency department visits are growing steadily every single year. 93,000 last year, and this year we'll expect to eclipse 100,000. So for a community hospital, very busy and complex institution, and we can brag to say we've got regional leadership in a couple areas: chronic kidney disease, which Nancy's responsible for, she'll talk to afterwards, stroke care, and that sort of stuff. We, like I said, are in a heavily growing community. Mackenzie Richmond Hill Hospital is the site we have now to support that growth. And soon, we don't have a nice, awesome flyby video to show about it and stuff because we don't know what the hospital is going to look like yet, or at least we can't share what the designs are yet because we're in the RFP stages. But we're set to build a new hospital and become a 2-site model in 2019. So that introduces some interesting challenges on its own. It's great to have that, but what we have to do in the next 4 years leading up to that is to support growth in one institution. So essentially, to prove to the Ministry of Health, I don't know if there's any ministry people in here, they could probably explain it better than I can, but we have to support that growth in our hospital and essentially be ready for that growth level on opening day in 2019 in our one site. So that obviously means that we need to be incredibly efficient as we grow in order to make sure that we can support that. So we've got 2 wildly important goals, which is how we do our strategy management, which is where an office that I'm part of. The first is to create an exceptional experience for emergency patients. And the second is to plan and get ready for that new hospital and 2-site model that comes with it. So creating an exceptional experience for emergency patients, which is where this work, most of it falls under. You can argue that it supports the second as well. And the reason that this falls under that is because obviously we've touched on it a number of times. Everybody except for St. Thomas apparently has problems with people holding an emergency department. And obviously that's not a great experience for patients. So we've got 3 drivers that we break that down into. The first 2 are for our non-admitted population. One is just meeting patients' expectations in terms of communications and managing fears, anxieties, and that sort of stuff. Second is trying to do some work around wait times for non-admitted patients. The 90% of patients that come to an emergency department that don't get admitted that we want to handle efficiently, a good process around. And where this falls is wait time for inpatient care for admitted emergency patients. So we talk about this, it's kind of our big wig right now, enhance bed use efficiency. We had a couple projects that we did last year that we've rolled into one now that were around reducing acute inpatient length of stay and trying to have a proactive discharge model in place, which is really around ALC and RFD reduction. And this project fits in with both of those. And when we started to get into the planning around those projects, this is the framework that we use for planning and managing all of our projects. And everything really starts with why. So framing a problem statement, understanding why we have that problem before we even think about what we're going to do about that problem. So those are our goals. The what becomes our project deliverables. Like I said, the what we're going to do about it. Then we would think about who needs to be involved in this as part of stakeholder analysis, who's going to undergo change as part of this, that sort of stuff. And then we would talk about how, finally, at the end, in terms of actually developing a project plan and thinking about what execution is going to look like. So like I said, why drives everything, and it kind of turns the crank on it all. And we set in place a very kind of supportive structure to manage those things. So we have a project team which obviously executes on a project like this. We've got project lead, which is usually an ops director at that level, who's Nancy on this project, and a project manager who's someone like me or someone from our office, which is responsible for making sure that we plan properly, that we execute like we should, and that sort of stuff. And then obviously we've got a project sponsor, kind of too many layers of sponsor, an executive sponsor too, but that's okay, it works. So that's how we do things, and I think it's important because you're going to see that the rest of this talk, when we go through how we decided that we needed to upgrade Medworxx, how we decided how we were going to frame all this in terms of setting up our goals and what we want to get out of it. That's where it all extends from. So going back to, like I said, we had these goals in place: reducing acute inpatient length of stay, proactive discharge approach, and we started talking, and obviously everybody says, well, we have Medworxx in place already. What have we got out of it? So we look at the data then. We implemented Medworxx in 2012, 2013, around that time frame. I wasn't there, but Kathy led it at the time, with support from all these folks, obviously. And if you look at the graphs here, on the top is medicine length of stay versus the provincial 25th percentile, which is basically just the expected length of stay target. The gray bar on the bottom there is the target, and the top line, which is purple, is our performance against that. The bottom graph there is our number of ALC patient days, and you see that after implementation there's a different time scale on these two graphs because we have different amounts of data, so that's why they're different there. You can see that after implementation we had a little bit of a reduction and then it didn't sustain. So in terms of thinking about the why, the goals that we had on a project like this, that's where it stemmed from, to say, how did we miss the mark? In other words, how did we have no significant improvement in those metrics that are key for us in most of our hospitals after we first implemented Medworxx? And the answer to that, and sorry Dan, Niles, and Ron and everybody else, is that implementing Medworxx on its own is not going to be a solution for anybody. It's not going to give you any improvement on its own. And we learned that. It's really a tool. And you're going to get out of it what you put into it, essentially, right? And through consultation with a number of folks at the conference last year, South Lake, Nova Scotia, Winnipeg, Thunder Bay, North Bay, a whole bunch of places we talked to in consultation. What we learned was that in order to ensure sustainable success of a tool like this, you need to ensure everyone understands and uses the tools, and that you really build strong infrastructure around it. So that's what we set out to do. So we built our why, or our project goals, based on that. And at this point, it didn't involve an upgrade. It was, what we need to do is this, and we'll think about how we're going to do it after that. So 3 things. Number 1, and this is what we learned from our discussions with all these folks that I just mentioned. Number 1, enhance access to and utilization of Medworxx across inpatient care areas. So make it easier for people to access it, make it easier for all the people that need to access it aside from just the patient care coordinators. And this is the most important part, I think, utilize the tool for additional communication and collaboration amongst the interprofessional team. That includes social work, OT, PT, CCAC, everybody that's part of that interprofessional team. We thought, and we learned, that if we can utilize Medworxx as a collaboration and communication tool for that, that'll help us a whole lot. Number 2, tightly tie Medworxx to daily operations for all clinical administrative leaders, physician leaders, community leaders, and support services. Essentially what this means is get it on everybody's radar. Make sure that everybody's day, when they're in the office, that any leader at any level of an organization is looking at some sort of Medworxx data, whatever's relevant to them, and that it becomes part of their day. 3rd, embed Medworxx terminology and concepts of patient flow throughout the culture of patient flow in all clinical areas. We want to start talking RFD, not ALC. We want to start talking met or not met rather than some of the conversations that take place. So those were the three main goals that we set out to achieve with the project. Now, like I said, at that point, we thought that version 5 and upgrading to that may be helpful for us, but we weren't committed to it yet. And obviously, our leadership team wanted us to explore and be diligent in understanding, can we accomplish this with version 4 or should we go with version 5? Obviously, since I'm talking about it, we made the case and we were approved to go forward with version 5. A couple of the reasons that went into that were we're talking about enhancing access to and utilization of the tool, having it be web-based, easy to access by any computer or externally from our hospital was obviously a win. If we're talking about getting that data in everybody's hands, the enhanced analytics and reporting that came with it, we're in support of that. But the case was, I think, easy to be made once we established those goals and we knew what things in the version 5 platform were going to be in alignment with them. Second major deliverable that we knew was important was complete retraining and certification of all necessary staff. Patient care coordinators are great with Medworxx, but it was important for us to make sure there was a refresher done. We did training of our management team, our unit managers, who previously were not aware of Medworxx. Some MRNs to support PCCs, hopefully more soon. I know we need it, but so complete retraining and certification to make sure that we've got a solid foundation. And then third, clinical workflows enhanced to make sure we made this thing easy to use for people, if we could. And assessments, compliance, and data quality plan enhanced. So if we want to start using this data, which is going to be the most important thing for us after that first goal of communication with it, making sure that it was on a really solid foundation of quality first. And then fourth, execute a data dissemination and action strategy, redesign that and execute on it, which we knew was a weakness initially. There's a whole bunch of acceptance criteria you could see afterwards if you want. So that was the what, and then we needed to talk about the who. So who needed to be involved in this thing to make it successful for us? What you see on here is the kind of typical structure that Medworxx suggested for us. We took advantage with the steering committee and some of the structures we had in place, the structure that we were using to manage a couple of our projects anyways, rather than add an additional layer of support that didn't need to be there. Project manager was myself, and obviously we have clinical leads, who were Kathy and Jackie back there, an IT lead, who's Albert, back there as well. And then we had a clinical team, small amount of people, and a bunch of IT people, obviously, that needed to be involved as well. But we knew that with the data component that we knew we were going to try and build into this, that we needed to add another arm to that, supporting both sides of those. And that's data dissemination BI lead. So we added a little arm there as well, which is Winston, who's the director of clinical utilization for us, and Anthony, who's here as well. And then it came time to talk about how. So how are we going to implement this thing? So it started with pre-project learning and explorations, which we were here at the conference last year, begged, borrowing, stealing any information that we could to inform this, which we did very successfully, by the way. Project initiation, which obviously you'll have on any project. And then there's a number of kind of main phases that we knew we needed to lay out for this, or main milestones. First was getting the training and certification done before the launch, obviously. Then was the actual upgrade. Next would be achieving a data quality and completeness strategy. Then we can look to thinking about achieving a data dissemination and action strategy. I know it drives Karen crazy to just say data dissemination. So. And then, hopefully, finally achieving enhanced operations with the tool. And then after that, getting to a level where we have continuous improvement utilizing Medworxx data. So the interesting thing, if you look on this graph, is if you quantify kind of on a scale here, and this is not a completely accurate scale, obviously, in terms of times and all that sort of stuff, and I could build that and it'd probably come out the same way. The time that goes into the upgrade component is minimal compared to the time that goes into the post-upgrade, refinement, optimization, and all that sort of stuff. Right? Hopefully not news to anybody, but if you're setting out on this journey, make sure you keep that in mind. This is what I'm trying to say. So a couple kind of key activities, milestones, tools, and that sort of stuff. And I'm going to focus only leading up to the actual launch of the upgrade. And Nancy and Kathy are going to talk afterwards about what we've done since, and what we're doing. So the first thing that we did was develop a data dissemination and action strategy. We developed it, right? We knew that that was the most important goal. It's the last goal, the hardest it's going to be to achieve. So it needed to set the foundation for everything that we were doing in planning and execution throughout the project so that we could go forward and actually execute on it afterwards. So what we did, and I'll talk about it in the next couple slides, is have some of the Medworxx crew come on site, and we did an entire day after we designed this data dissemination strategy, what our vision was. We had their team come on site, facilitated a session that was split amongst different levels of our team throughout the entire day to design the nuts and bolts and how that was going to come together. Before we did that, we came down to the Medworxx office and we did a complete deep dive into the history of the tool, the data that's in it, what met, not met, all that sort of stuff meant for all of our leads on the project and our sponsor. So Nancy, Anthony, Winston, Francis, our executive sponsor, all that sort of stuff, to make sure that we all had an understanding of what that data is going into this. So that was around the data. We developed enhanced training and certification materials. Like I said, did full retraining and certification of all super users. Leading up to the upgrade, thorough functional testing of the application and all the interfaces, which you can't stress enough is important. And then did some, utilized some rigorous project management in terms of understanding where we are in our journey, leading up to the upgrade and where our weaknesses potentially were so we could address them, typical project management stuff. And then afterwards, collaborative and timely issues documentation and management, thorough documentation and lessons learned to help folks, to help Medworxx and future folks that are going to go through this upgrade process, make sure that you don't experience some of the bumps that we did along the way. So to start from the beginning and go into a little more detail, this, I think if you remember anything about this talk, this is probably the most important slide by far. This is the data dissemination vision and strategy, whatever you want to call it, that we put together that really drives everything that we're trying to do now. Like I said, that we haven't accomplished yet, but we hope to. So the top is the goal. We decided that how we wanted to express this was that we wanted to optimize and integrate Medworxx data to daily operations and ongoing improvement efforts with all interprofessional team members and all levels of leadership to remove barriers to discharge and enhance patient flow. You see along the left side, the way we visualize this is the different kind of major levels of the organizational structure that need to be involved with Medworxx data and understand Medworxx data, starting with the interprofessional team, then to the manager level, supporting them, then to the director level, and then to the senior leadership team. Everybody's got a part to play, and we drew up what those parts were, in our opinion. Then on the top there you see in gray, we've got the daily operational focus, so a focus on current patients that are in the hospital, and in purple, the retrospective focus. Like I said at the beginning of the talk, we wanted to make sure we utilize this in real time as well as afterwards for improvement efforts. So the way we've got this visualized is that the longer the gray bar is, the more we see those folks needing to be involved with current focus patients, and the longer the purple bar is, the more we see those folks being involved in retrospective analysis. And you can see that as it goes up through the organization, it shifts more to purple and less to gray. Because if you're the CEO or if you're Nigel and you're the COO, I mean, you got to be a little bit worried about what's going on currently, but the way that you can help your team more is to help make sure that those problems they're experiencing now on a grander scale are addressed, and that larger improvement efforts, you're committing the time and resources that need to go into those. So I won't go into the details of this, but essentially that's how it flows out. And on the bottom is kind of the foundation of everything that we thought would support this from a foundational principles perspective. So things like quality data that's trusted. If we want to use this data at all levels, it's better be good, as Anthony would preach to us. Validity and reliability across assessors. So not only do we want quality data, we want it to be consistent. We'd rather have all of our PCCs coding data in the same way if they agree on it than in a way that somebody else may say is the right way. Common understanding of data definitions by all. I think it's been touched on a lot. Targeted, timely, and useful reports sent to the people that need them. Add value and help with efficient workflow rather than add work. Strong, consistent governance and accountability at all levels. And embedding Medworxx data in terms and operational reports. So all that sort of stuff built the foundation for what we wanted to do. So like I said, what we did was, after we got that drafted up, took it to our senior leadership team, said here's what we think we need to use this tool for and how we think we can be involved. We got the stamp from them and approved. Next was, how do we bring this to life in terms of the nuts and bolts? After we go through the upgrade, how do we want reports to get in people's hands? What do we see them doing with it? All that sort of stuff. So the approach we used there was, like I touched on, a one-day facilitated planning session that was broken into groups. The same groups that were displayed on the left side of that previous slide there came in, and we started with the interprofessional team, and then we went to the management team, and then the director team. And unfortunately, that day, there was a Lynn thing going on and our senior team didn't get there, which is probably the weakness that we've got now. But at least to that director level, we planned it all out. So we started by talking about, if this is what we want to get out of that, based on what we've detailed on the last slide, what information would you want to act on? How would you want to receive it? And how can it get in your hands so that we can act on it and achieve those things? And then at the same time asking, okay, if you're at the PCC level, what would you need from your manager at the next level to know that they're supporting you in that? And then at the manager level saying the same thing, what do you need from the director level to make sure that they're supporting you in that? So we went through that, we documented it, and it started to inform some work that we started doing with Larry and Andre and the Medworxx team around building those things and actually making them happen. And Kathy will touch on what's going on with it later. The next important thing to keep in mind is this project status updates and delivery assessments that we were doing throughout the actual upgrade. And I can't stress enough, if you're about to go through this upgrade process, not that it's a plug for my background and profession as a project management professional, but you really do need somebody in your organization that's an actual project manager on this, not layered onto somebody else's job. This took up a heck of a lot of my time and focus and attention, in addition to the time and attention of Kathy and the clinical team and everybody else. It's not an upgrade, it's not a process that somebody should be managing on the side of their desk. So just understand that, I guess. So the weekly status calls that we did with Medworxx were really helpful, touching base with Denis and the team, understanding what's been done on their end, what's been done on our end, making sure that we're all on the same page. And that's more of a technical focus. How are we progressing in the build of the solution and the test of it and all that sort of stuff versus the plan that we have laid out. And then what I did in addition to that was a weekly status update and what we call a delivery assessment. And what that is, this went out to all of our stakeholders, both within Mackenzie Health and the Medworxx team and the key people there, Larry and Andre and Joel and that sort of stuff. And this is more of a comprehensive focus. And the goal here is to understand, are we on track to actually deliver successfully post-implementation? Confident that we're going to get the actual product delivered on time, on budget, and that sort of stuff. It's actually the easy stuff. How likely are we to have success afterwards? So that's what that focused on. It breaks down into a red, amber, green, amber, red, or green focus. You notice there's no middle ground there. You got to kind of score the likelihood to deliver on that. And luckily, throughout this whole process, in my opinion, my expertise, we were green, and I think we still are, so that's good. And the next important thing was comprehensive issues management. So when we got to the launch, we knew there's going to be issues. With something like this, hopefully they're minimal, but there's always going to be something. And I think that we did really well on this. There were a number of issues that came up in the first couple weeks, nothing that was catastrophic, and all that were manageable. And they were managed very well, in my opinion, from both sides. So it was a good thing. Again, we've got this documented, and we could share if anybody's interested. What these issues really came down to was mostly two big buckets. One was interface issues, so the ADT system connections and sending messages and processing messages in the right way, which is obviously very important in software like this. I want to make sure that people get the information, it's the right information, that discharges are processed in the right way, patients don't remain in beds when they should be gone, that sort of stuff. Some mappings of information. We had some issues where, for instance, after a patient was discharged, if there was another information message that came through, then the mapping of that information wouldn't come across with it. We could no longer know what bed they were in or what unit they were in when they were here. That's fixed now. It's important information, obviously. And ALC WITIS. So there were some issues with that. We were in a unique position because we launched this, was it 4 or 5 days before the big WITIS upgrade in Ontario, because we wanted to get ahead of it, knowing that Medworxx resources were going to be kind of heavily committed to that a week later, and we wanted to make sure we had the ability to address any issues that came up. And I think that was probably what drove a lot of the ALC issues that we had. Again, all that were managed well. So we've got complete lessons learned documentation as well that we went through as a standard part of project management. And if I had to pull kind of overall lessons learned out of that to share with folks, then it would be a couple things. One, early on, we had a project plan, we had a schedule that we knew we had to adhere to, but I think we didn't treat the dates that were in the project as firm enough early on. Not saying that was our issue or the Medworxx issue, it was a joint thing, but we needed to treat those dates as more firm. And the reason being that we had buffer built into our schedule as you would in project management, but we ended up needing that buffer later on, and we kind of burnt it up early on, right? For no real reason other than the fact that we didn't treat it as seriously as we should have. And what that ended up impacting was that we had essentially no live in the dark period. So messages actually live messages getting processed for a week or two before going live is how you really should function, and you really want to make sure you get that, because I think a lot of the issues that we encountered afterwards, after going live, were issues that we probably could have caught in that live in the dark period and never have made their way to our team, which graciously reported them into us and we dealt with, but we probably could have avoided them ever experiencing that. One thing that I should add to the conversation here, what we did was we added an email address for our users, medworxx_help@mackenziehealth.ca. So after the upgrade, we made sure that our users knew that they could submit issues that they were having to that email address. And what ends up happening is it gets routed to Albert, who's our IT resource, myself, a couple of other IT resources and that sort of stuff, and the whole patient flow team, in case it's about reports and that stuff. So that we, as a team, can know what's coming into us and react to them pretty quickly. And I think it's been pretty helpful and successful. So just a tip maybe to think about. And the other thing is, we did, and I have to really congratulate Albert and the IT team on this, they did extensive testing over and over and over again, uncovering new issues with each round, which is okay. We had time to deal with them. But I guess the message here is that the load on the IT resources, because of that iterative testing that we were doing, was heavier than it would have been estimated in the project plan. So if you're talking to your IT folks and you're going through this process, make sure that you've actually got somebody set aside throughout the upgrade to be there as your resource, not just an IT lead, but the people that are going to be, mapping your ADT systems and all that sort of stuff. Would you say that it was essentially a full-time gig for you for the couple months, Albert? So thanks, Albert and the team for that. And that's about it for now. Like I said, we've got it set up so that after the break, Kathy and Nancy are going to talk to more of what we've done after the upgrade process. But if there's any questions that anybody has now, we got some time that I could take specifically about the upgrade.
Just wondering what kind of timeline
Our kickoff was late March for the project when we finally had the contract signed and we had the Medworxx team in. And we went live with the platform on June 3rd. So, no, 3 months. Yeah. There was a lot of work that went into it before that. Like I said, we really started this process at the conference last year, which would have been October. Starting explorations on how we were utilizing the tool, if there was value in pulling together a project for the upgrade and that sort of stuff. So we slowly built up. We had some things to deal with internally in terms of approvals like we always do, and we finally got the official approval in March.
So William, my team knows that I'm tough to manage, and after 3 years of dealing with me, I finally have an industrial engineer who's my project manager, so they appreciate that. That being said, for these types of projects, it takes a lot of cultural transformation and leadership from the top. And so the question I have is, do you have adequate leadership from the top? And that may be a loaded question because you have leaders here in the audience. But I think for all of the health systems that are putting something like this in place, we're trying to change. We're not trying to use a technology, we're trying to change a culture. So could you just sort of comment on that?
Yeah. Sidestep it.
No, I don't want to put you on the spot, but I think it's an important part of a project.
For sure. And I think if you look at any literature, projects, changes, whatever you're trying to implement, the reason they fail is because of a lack of senior leadership buy-in and support. Obviously, that's number one. There's a lot of other reasons it could. So I guess the answer is yes and no. We've got incredible support from Nancy and the team, who's our director of Patient Flow. Going up a level, we've got great support from Francis, who was going to be here but is dealing with a small issue of new hospital design and stuff like that. Above that, I think, is where our weakness is. There's a lot on our leadership team's plate right now in terms of dealing with our future planning and stuff like that, and I think if there's a weakness, it's definitely it. And you're right, you really needed to drive this in all levels of the senior team if you truly want to be successful, and I think we've still got a lot of work to do to get them truly committed. They did approve the vision and strategy of the data dissemination.
No, I mean, we're going through a hospital upgrade also, and that's where everyone wants to suck their energy towards is, the vision of the future. But you pointed out very nicely at the very beginning, the day-to-day operations are what's going to drive the vision of the future. And I think from all of us as leaders, we have to sort of make that an important part of our organization if we're ever going to get those towers.
And I think I recently facilitated a retreat for our senior team, and we were talking about a lot of that. It's what is their role in that future hospital design, and if you really think about it, we're also upgrading an EMR platform soon, so that's kind of big too. But there's a lot of structure and governance built in to manage those things, and it essentially doesn't really need to involve them too much, but that's where the attention and energy tends to go to. And yeah, I think that this really should be a heavy focus.
So, I was just curious about, you retrained all the different levels I hear. So the care coordinators, managers, right up to physicians. And I was wondering about how you did that, and if you used a different methodology for the different groups, or how you obtained that.
So maybe it didn't come across quite right. We trained the patient care coordinators and the managers on the criteria set. We did retraining. We haven't touched the physician group yet, kind of purposefully. I think we wanted to really make sure we waited for solid data quality and completeness until we could bring that to them. Obviously, the way that the physician mind tends to work, Mark could speak better to this, but if there's a crack in the armor of the data, they'll find it, and they'll raise that flag to say, it doesn't work. So that's where we want to focus now, and we will get there, and there'll definitely be a different strategy to approach that. What we have done, and Kathy and Nancy will talk to it, so I won't talk too much about it, is we've engaged the rest of the team who doesn't do the status assessments and some minor education about entering information in a standard way in the comments fields. So that's how we've handled them.
Just the bullet that where you were talking about your live in the dark piece. Can you just explain that?
Yeah, I think because, so we had in the plan for a 2-week live in the dark period. Everybody know what live in the dark is? Who's been through this process before? Essentially, that means that your system's running in the background, getting live patient feeds and that sort of stuff. You're just not using it yet. We planned for 2 weeks of that, and I think because of not enough rigor in handling and maintaining some of the key dates early in the project, we ended up eating buffer that we could have used at that time to make sure we still had a live in the dark period. What ended up happening is we met our go live date, but we ate up that buffer, so we never had any live in the dark. So essentially, the day before we went live is when we switched it on. And I think some of the Medworxx team may remember it was up until like 8 or 9, potentially later that night, that we were still wondering, do we need to roll this thing back? Because of some issues that were coming up. So very important period. Did that answer the question?
Yeah.
Thanks, guys.